Good morning, everyone. My name is Reg Scheller. I'm a family physician, president for academic affairs for the Institute for Family Health, and vice chair of family medicine at Mount Sinai in New York City. We are delighted to have Dr. Teresa Wood join us this morning, who is currently in British Columbia, so it's the ungodly hour of 5 a.m., and we are very grateful for her being available. She's going to talk today about sexual health and sexual education, and has a really interesting career. She's a performer, poet, and philosopher, and medical doctor. A very unusual and obviously useful range of skills, especially in this work. While studying philosophy at the University of Chicago, she developed a strong interest in the ways in which science and belief are applied to our bodies, our wellness, our sexuality, and our education. Dr. Wood began her career giving seminars on sex and intimacy in an effort to help people unlearn old school sex education and foster awareness, empowerment, and access to healthy relationships. She opened a sex and intimacy coaching practice for individuals and couples who were inspired by her seminars to enjoy their intimate lives more fully, and she has continued to work with teenagers, adults, seniors for over 2 decades. In 2006, she earned her medical degree from the University of British Columbia in order to pursue her interest in sexual medicine. Dr. Wood believes we need to change our approach to sexuality and sex education if we want to benefit from all our brains and bodies have to offer in terms of full expressions of wellness and pleasure. And that a focus on the physiology of pleasure will give all genders the tools to understand each other, please each other, and communicate for everyone's benefit. In addition to her seminars and coaching practice, she works as a physician lead at the Options for Sexual Health Clinic in Whistler, British Columbia, where she provides STI screening and treatment, gender-affirming care, contraception, IUD insertions, and other services to patients of all ages. She also provides gender-affirming care and hormone and surgical readiness assessments to transgender and non-binary individuals at TransCare BC, a program under the Provisional Health Services Authority of British Columbia, which connects transgender people, their loved ones, and clinicians with information, education, training, support, and surrounding their healthcare. Thank you, Dr. Wood, for joining us this morning. We look forward to your talk. We'll hold questions to the end. So welcome, Dr. Wood.
Good morning, Mount Sinai. I know it's 8 o'clock in the morning there. It's 5 o'clock in the morning here, so you might have a little bit of my Jaja Gabor voice for this sex function discussion. I have nothing to disclose. I'm not sure why my slides aren't moving forward. Let me try that. There we go. It's not sliding forward. Give me a second here. I'm going to take that away and try this way. There we go. I have nothing to disclose. We have lots to just demystify this morning. Again, I'm Dr. Teresa Wood. You can find me on Instagram and Facebook. We're going to cover a lot of things, and sometimes it's important to remember like whose bodies we're talking about, whose facts. As medical trainees and medical practitioners, we learn a lot of facts. We are often taught them as fact. Some of the facts we have learned over time are things like the earth is flat, and then later we discover that the earth is not flat, and then we discover it's also not round. And so facts are a very changing thing. I am a student of philosophy. I studied philosophy at University of Chicago before I went into medicine, and I was very interested in the ways in which we applied science to female bodies and trans bodies and non-gendered bodies. And so I'm very interested in how facts change over time, how we come to knowledge. We are currently very interested in evidence-based medicine, which works for large randomized controlled trials of a little white pill. But if you're studying something that isn't a little white pill, you've got a small problem or a big problem because you can't really study it. So much of the knowledge that we have acquired over time for cis white males had come at a time when experiential medicine was very involved. You know, we did interesting things like taste urine to find out if it was sweet or salty. So these kinds of things are not, typical, what we now understand is the only way to come to knowledge. But as a philosopher, I remember that there's multiple ways to come to knowledge. So it's very important for me that we continue to listen to our patients and we don't act like we are the fact providers and they are right or wrong, rather that we are learning from each person because there are so many facts that we don't yet know.
Dr.
So
Wood, I'm sorry to
pardon?
interrupt. We're not able to see your slides. I think you still need to share your screen.
Oh my goodness. I was sharing the screen, so oh, there we go. Thank you for letting me know that. Let's try that. Are you able to see that now?
Yes, we are. Perfect.
Okay. Thank you so much for letting me know. Okay, so of course we're covering a lot of touchy topics. It's very important for listeners in this kind of environment to just notice a little bit how you might be responding or reacting to some of the things that are being said. Remember that nothing I'm saying is true or factual per se, because I don't believe in facts. But they're all things that we've acquired over time, and you just hear what you want to hear and you process it and you decide what is true for you. And that's going to be the case for all of our patients as well. We are guiding them through their health choices as best we can, as respectfully as we can, to provide them with a informed consent. So, and of course, we're talking about very sensitive parts of bodies. And these are things that have often been very taboo. So when we talk about the medical implication of semantics, semantics is the study of the way that we use words. And when you think about the fact that we have named the part of the body that we're mostly discussing today, the pelvic area, we've named it the pudendum. We call it the pudendal nerve. The word pudendum comes from the Latin to be ashamed. So if you're wondering why we haven't studied the pudenda very much, it's because we called it the shame area and we literally didn't want to touch it. So fortunately, because many of the physicians and scientists were men, then the pudenda of the males has been studied. It wasn't considered as shameful, but the pudenda of the female, the area to be ashamed of, is just now starting to be looked at. So if there's someone who comes in and says, hey, every time I get excited sexually and I'm very excited, I squirt all kinds of fluid all over the place, and we don't have any information to guide that answer, then the answer is not, oh, well, you must be peeing. The answer is, oh, that's interesting. We have no idea about that entire part of the body and we need to study it more. But if it gives you pleasure, then it gives you pleasure. So I just invite you to have a curious attitude about these things and remember that semantics and the use of words in our science and the way we apply ethics to human bodies has really altered and changed how we can study these things, including now it is very hard to study sexual health and get past the ethics, which are there to provide safety for patients, but have really come at a time when we know so much about cis white male bodies and very little about bodies of people of color, non-binary bodies, female bodies, etc. So what are the implications of not knowing very much about the sexual pathways for women and non-binary people? Well, one of the issues is if we have created an education system where 50% of the population is always having orgasmic pleasure with their sexual activity, and 50% is almost never having orgasmic pleasure. What we're doing with our reward system in the nucleus accumbens of the brain is giving a lot of reward to 50% and almost no reward to the other 50%, which causes a power dynamic in society as a whole that can lead to things that cause a little bit of a forced or coerced kind of activity in the direction of one of those groups of people. And we end up with something that requires a movement to settle it down. So instead, we could re-educate, we could refocus, and that's part of what we're going to be discussing today. So we're going to do a quick review of the anatomy and really start to understand what's going on for female sexual pleasure. We're going to talk a little bit about why we have taught mostly a system about penetrative sex, PIV sex, I'll call it on occasion. That's just the penis and vagina. That's kind of the way they talk about it on Instagram. And why a focus on that has really caused that kind of libido disparity in our society. And then we're going to look at sex and gender differentiation through kind of like the genetic pathways, and discuss what natural diversity looks like in this department, and how we've used our words to bad and wrong certain changes and variations in nature. And then we're going to, if we still have time, which I hope we do, we're going to have a quick talk about women. Do women and people of color have pain just like everybody else? And spoiler alert, they do. So we're going to talk about how to actually not gaslight everyone who is having pain, who is having procedures that were typically done by male doctors on female bodies, and therefore often diminished the pain, or the women were deemed hysterical instead of actually in excruciating pain, and how that's passed on so that we still under medicate female procedures, and how we can fix that. Okay, so let's get started. First case, we have a 45-year-old professional cis female who presents with no libido. She's in a monogamous relationship with a partner similar age who's a stay-at-home dad, and who has recently acquired a prescription for Viagra due to his own erectile dysfunction. They both deny any SIGA caps, which we use in Canada to assess for CNS depression. And neither of them are using SSRIs or any other obvious medications that would have a major impact on her situation, although she is on oral contraception. And then when we ask her about orgasms, well, yes, she sometimes does have orgasms, but only when she's alone, practicing self-love, and there's a little bit of pain associated. And then with her partner, she used to maybe 50% of the time, but it's decreased over time and rare since she has kids. Her kids are aged 5 to 13. She complains about dyspareunia, which is pain with penetration, and it's a little reminiscent of when she was breastfeeding. So we're just going to go through some of the quick key points. How is libido affected by pain? Rewards, brain, energy, hormones, and medications. So in this particular patient, there is, oops, I went one slide too far. Give me a sec. Okay. There's, in this relationship, there's a little bit of a PIV focus, a penetrative sex focus. The MD for her partner has given her some Viagra. We're not sure if they asked about how the partner is doing, if they're having pain with penetration. It's very helpful. A lot of men do come in around this age and they're starting to have erectile function issues. And it's possible that some of those women are also starting to have perimenopausal symptoms, and maybe they're excited that they're going to be going back to a less penetration focused sexuality, and now here comes the Viagra, right? So it's not always good news for the women when the partner comes home with that if they're already having some issues. You need to address sexual issues with all the parties involved. So in terms of orgasm, she hasn't had an orgasm with the partner before kids. Now think about the implications of that. There are so many people, you know, in my first 2 decades of practice, I spent a lot of time just educating women how to have an orgasm. Nowadays, younger women in this next generation, with all the social media, there's so much more information, but make sure your patients know what an orgasm is. Make sure they know if they're having it or not. At the loss of orgasm over time is the loss of reward at the nucleus accumbens, and we will discuss that. So medications and systemic factors, well, we've screened for CNS depression, which definitely can affect a person's libido. We've screened for SSRI and SNRI use and other medications that could be affecting it, but they're not using those. She's obviously a working professional mom. Her profession is a giving profession, as we know, and she's got young kids. So are her needs being met? Is she coming home exhausted from giving to everybody else? spending the evening giving to her kids and family, and then somehow being expected to give in terms of sexual response? Or is her sexual encounter involving receiving? And with the dynamic of penetrative sex as the primary focus, we are sometimes losing the receiving end for the female partners. So in terms of age and contraception use, she's still using contraception, which is wise at this age. She's 42 years old. She could be perimenopausal. Certainly, we know that we start to lose our testosterone levels around the age of 36 to 38, dropping off towards the age of 46 to 48. And so, and we kind of have a linear drop in testosterone for women. We don't often think about testosterone for women, but we are starting to think about it much, much more. Estrogen seems to start to go all over the place during perimenopause, and then right near the end, it drops right off. And that's when estrogen might need to be replaced for those who are symptomatic. But testosterone is more of a gradual decline, and it doesn't go completely away. But as it's going down, there is a loss of some of the things that testosterone provides. And a lot of the tissue of the vulva and the first couple inches of the vagina are very, very testosterone sensitive. So in this case, she's on sex hormone, she's on oral contraceptives, which, as we know, will give her a high sex hormone binding globulin, which can kind of eat up the estrogen and the testosterone. And so even if you're seeing reasonable testosterone levels, they may be bound to the sex hormone binding globulin, and she might not be seeing the testosterone she's used to seeing. And then, of course, that the end organ, we've got to think about the vulva and the clitoris. Make sure you do a physical exam. You cannot talk to women about painful sex and discomfort during sex without looking at the vulva. You need to get comfortable looking at the vulva. Every time you do a pap exam, look at the vulva. A normal, healthy vulva will start to become a habit for you. The coloration, many of you are seeing people of various ethnicities. You need to start to understand what looks normal and what doesn't, so that you know when to refer or when to question, or when the symptoms that the patient's describing are matching a change that you're seeing in that vulva. So let's talk about one of the aspects, again, this penetrating thoughts about penetration. So we have developed a system where we were only allowed to teach sex education to prevent STDs and to prevent young pregnancies, unwanted pregnancies. We begged governments for the rights to talk about sex in the first place, and that was the only sex we were permitted to discuss. So we have accidentally silenced all other forms of sexual activity by really, really focusing on penetrative sex. The good thing for some people is that 98% of penises tend to have no problem reaching sexual orgasm from penetrative sex. Unfortunately, for those who are receiving the penetration, those numbers are abysmal. So 82% of women do not come from intercourse alone. And this means that 82% of women, if they are not practicing a form of sex that involves their clitoris, they are literally not having dopamine rewards at their nucleus accumbens. So without the clitoral orgasm, we are seeing low libido results. And the solution is not medical. There are no medications that are going to solve this problem. A vibrator might solve this problem, but really it's education. We really need to teach people that just like you don't start to touch a penis to get it hard and start to stimulate it and then stop touching it altogether and look the other way and hope it's just going to come on its own. You really do need to continue to touch the clitoris and rub it in a way that is going to stimulate it all the way until it does reach orgasm, so that it is rewarded at the nucleus accumbens. So I'm going to drive this point home as much as I can. Here's just a really basic schematic to show you that the clitoris and the penis are the same organ in terms of sexual pleasure function. They both have the glands, and they both have the shaft, and they both have the crura. The bulbs of the clitoris do surround the opening of the vaginal canal, but once you get through the first 2 inches of the vaginal canal, you have very few vibration sensors. All those dildos that look like penises that go inside and vibrate, they're not doing anything past those first 2 inches. So it's important for people to understand the anatomy so they know where the touching needs to happen. And of course, there's 1,000,001 memes online about those jokes, but whether or not people can find the zipper to the purse. It is extremely important for women themselves to know where it is and to know how to drive their own clitoris. So one of the things I like to teach women is to free their mind and allow them to practice masturbation so that they can learn about their bodies, so that they can teach it to someone else. And if it's hard to teach it to someone else, or they're unable to come in under someone else's touch, there's no problem with them being the ones that drive their own clitoris during intercourse, before intercourse, and after intercourse. What's important is that we have mutual orgasmic shared pleasure that results in mutual stimulation of our brains to do that again. So I've just put this up here just to show you a little bit of the intersex anatomy as well. So of course we've got the clitoris here. This is the phalloclitoris, the hypospadias penis, and the penis. And this is just a schematic of how those might look on the body, and just to show you how analogous these structures are. Obviously, the penis also works with its urethra coming through, but the pleasure organs and those things innervated by the clitoral nerve and the cavernous nerve and the pudendal nerve, these are all parts of the spectrum of intersex. And of course, we'll talk about how much wider that actually is. But that's the focus for sexual pleasure. If we're looking for not just arousal and is the person wet enough to receive someone else's pleasure, but is the person aroused enough to arrive at something that's going to give them that release of dopamine and serotonin and norepinephrine in the brain. So this brings us to, does size matter? Very common question. Well, it kind of does. And why is that? Because this is your primary sex organ. This is the most important sex organ. Your brain can turn you on, your brain can turn you off. One of the biggest problems so many women have is the hangups in which they are raised will stop them either at the beginning of sex, in the middle of sex, at the end of sex, or right before orgasm, or during orgasm, with all these kind of ideas of how their bodies are supposed to be, how they're supposed to be, the sounds they're supposed to or not supposed to make, and the fantasies they're supposed to or not supposed to have. What I like to tell people is my kind of feminism is that kind of feminism that allows you to reach orgasm, and I don't care what you do in your brain to get there. But anything that's interrupting you from that, you can just say, okay, little brain, just I hear you, but I'm not interested. I'm busy getting excited right now. On the other hand, if you're having fantasies that promote arrival at orgasm, then those are the ones that you need to focus on. And it doesn't really matter what they are, because we have freedom of thought. We're losing a lot of other freedoms, especially on your side of the border. But freedom of thought you will always have, and you don't need to worry about what the other person thinks about what you're thinking, because what you're thinking is just for you. Use what you use for masturbation with a partner, and I'm okay with that as long as it gets you and your partner to enjoy your full sexuality. Pardon me. It's that early morning voice. So orgasms are rewarded in our brain. We get a dopamine bomb at the nucleus accumbens. Our nucleus accumbens is our reward center. So we are rewarded for things that are going to promote the growth of the species. So we're rewarded when we drink, when we eat. We're rewarded when we defecate and when we urinate. And that's because if we didn't do those things, we would die. So all of those things are important for the survival of the species. And the last thing that we're rewarded for is orgasm at the nucleus accumbens, not arousal, orgasm. So having all these women aroused enough to receive penetrative sex and not having orgasms could lead to what I call pathological cuddles of the frustrated woman. So I'll never forget when I was in the surgical ward, operating, and I was a medical student, and the doctor was talking to the male nurse to try to embarrass me and talking about how over cuddly their wives were. And I just said, well, an over cuddly wife sounds like an unsatisfied wife. And he kind of dropped the things into the field and looked at me and said, what are you talking about? And I'm like, well, yeah, like a satisfied woman rolls over and goes to sleep just like everybody else who's satisfied. And he made light of it and then said, Dr. Wood can close up. And I got to go talk to my wife, grabbed a suitcase and ran out the door. It was just a reminder that those aren't the things to joke about, because it's kind of putting you in the spot of wondering if you're doing all the things that your partner needs in the realm of mutual orgasmic sexual pleasure. So our libido is driven by those rewards. So if we're rewarding the male of the species, we should reward the female of the species. We should reward everyone in the species, no matter what their gender is. And so for people with clitorises, that means you need a clitoral orgasm, as far as we understand, to keep that libido driven. And how do we get there? Well, self-love is often the easiest way for people, using vibrators in bed with their partners learning how to use their fingers, because the fingers can do a lot more fancy dancing than just a plain old in and out action at different angles. And the fancy dancing of fingers can sometimes access what's called the G zone, which is really like the internal access to some parts of the clitoris and also the periurethral sponge, where some scientists believe that we might be seeing the formation of ejaculate fluid for females. And obviously the tongue is another access to that. And please don't stop. You don't, like I said before, we don't stimulate the penis until it's hard and excited and then stop stimulating it and wonder why it is not getting off. You don't stop stimulating a sexual pleasure organ before it reaches orgasm and expect it to miraculously orgasm. So that brings us to the quick topic about foreplay. Foreplay is not just for play. Foreplay is the sex for women, because most of foreplay is centered around the vulva and the clitoris. And as you can see, even though the bulbs do come around the introitus and may be stimulated by the penis, and as those bulbs are engorged, then they help to stimulate the penis, you can see that you could completely miss the clitoral activity where the glans is and where the shaft of the clitoris is if you're only focused on the entrance of the vagina. So what is foreplay? Well, it's the sexual stimulation preceding intercourse. And of course, intercourse is not identical with sex. So it's worth noting that it's not the sexual stimulation before sex, which makes it the foreplay part and not the foresex part, when really it pretty much is the sex for women. And ask the lesbian couples, there may be some penetration, but they often don't even use penetration at all, because they understand that the goal is mutual orgasmic pleasure, and orgasmic pleasure often comes with or without penetration at all. Some people love it, some people don't, but definitely requires clitoral stimulation in most people with clitorises. So I call it the new old sex, because most people start their relationship with a whole bunch of wonderful foreplay. And often when they come to see me and they have low libido, and I say, well, when was the last time you had sex? And they'll say, oh, well, just last week. And I'm like, well, when was the last time you orgasmed? Oh, well, back when we were dating 2 decades ago. And then we realized that they haven't had orgasm since they reached the point of getting to the home run, and they decided to skip all the bases from then on and go straight to penetrative sex, leaving the woman without her sex, which is something that's going to lead to her orgasm. So I'm giving you a couple unsolicited vulva pics here. I'm just warning you in advance, because I was recently at a conference where many dick pics were put up on the screen, and I wasn't expecting them during my lunch meeting. But I'm showing you this because it is part of the physical exam, and I know that the quality of these pictures is not great. These are vulvas that you need to know about, because of a normal healthy vulva, which you should get used to looking at, should not look like this. This is an atrophic vulva. This vulva is too pale. It's closing, it's red and it's sore. The urethra is prominent but tender. This person probably experiences lots of UTIs. UTIs have a lot of morbidity and mortality associated with them as women get older and take more and more and more antibiotics and develop resistance. The treatment for this is not antibiotics. The treatment for this is vaginal estrogen. Vaginal estrogen is extremely safe. We are working really hard to get the FDA to remove the black box warning on it. You can use vaginal estrogen all the way till you die, and it's not going to affect you. You can even use it if you have previous breast cancer, but do talk to your sexual medicine doctor about that. The uptake is so minimal, the dosing is so low, and it is so safe, and it is such an important prevention of UTIs, but also allowing continuous access to sexual pleasure. This person's clitoris is almost obliterated here. Wouldn't be surprised if you tried to pull back that clitoral hood, if you would even see the glands of the clitoris in there. This person will need vulvar, not vaginal estrogen. They need vulvar estrogen. And when someone comes to tell you that their clitoris is painful and their clitoris looks pale like this, you need cream on that vulva and the clitoris. Even before they're going to be able to get something inserted in there to provide vaginal estrogen. This is a very kind of hard picture to see, but this is lichen sclerosis. You very rarely see that much lichenification, that whiteness, but what you often see is loss of architecture in the vulva, where you're seeing the fusion of the labia majora and minora, the fusion of the clitoral hood. When you look at a vulva, you need to tell the patient that you're going to just put your hands gently on them and spread things apart to see if things are moving properly as you spread them. If there's a fusion along the line between the labia majora and minora, then you're losing architecture, and you've probably got an inflammatory disorder that needs a biopsy. You need to refer that person to someone. Lichen sclerosis and lichen planus can lead to vulvar cancer. They can be excruciatingly painful. They can stop people from biking, enjoying sex, and even from masturbating. So this person warrants a biopsy and treatment. The treatment is typically cortisone cream, but we like to have a diagnosis, because if they have it, then they need to take the cortisone cream all the way till they die, and they need to do it twice a week after they've done a long course of it. So it's good to send it not to a gynecologist that never does sexual medicine, preferably a gynecologist who knows about the vulva, or a sexual medicine doctor for biopsy. You've got to look at these vulvas. So how can family medicine help this patient? Oh, in so many ways. First of all, you're going to encourage her to have her kind of sex, focus on the clitoris, understand it, understand how we can access the clitoris on the outside and just a little bit on the inside at the same time, and how the fingers can be helpful with that. And that's how we're going to increase her libido most naturally. And if she's not having that, none of the other treatments are going to work. So you got to get her to the point where she's actually having her natural dopamine dosings. I encourage them to practice self-love as a learning tool, and then as a teaching tool for their partners. They know what they like, so they can teach what they like. Encourage them to bring toys and vibrators to bed. No one should have their ego affected by having tools in bed that allow for mutual orgasmic pleasure. I encourage couples to take a break from PIV sex altogether and refocus on shared penile and clitoral orgasm, so we start to understand that both should happen every single time. And then I think about IUDs. High dose progesterone IUDs can lower the estrogen and give us an early picture in premenopausal women of what we'll later see in menopause, which is just that de-estrogenification of the vulva. When you see that in someone who's on like a Mirena IUD, give them 2 weeks of vaginal estrogen. If it changes their life, keep them on it. It's extremely safe. It's an extremely low dose for a premenopausal woman. In terms of oral contraception, think about sex hormone binding globulin. The best one for that is to use a low dose one like Aless or Avian or Alicina, as they're called here. Aless is the name brand. And because that sex hormone globulin is gobbling up your testosterone and lowering your libido, also lowering your ability to accommodate within the vulva and the comfort, and causing possibly some pain. We do have vaginal vulvar testosterone compounded, and we also have DHEA, which gives you a bit of testosterone and estrogen. Those tissues are very, very testosterone sensitive. Testosterone is a very important part of vulvar health. Involve your pelvic physiotherapist. They're amazing. Everybody should have a friend who's a pelvic floor physiotherapist. If you have no idea what's going on, send it to them. They will come back to you and say, actually, this is above my head, or I got her sorted out. Everyone should see a pelvic floor physiotherapist if they're having sexual pain. Never tell someone that sexual pain is normal. It's never normal. If sexual pain was normal, we wouldn't have a species. We should have comfortable sex. A lot of what the pain women are experiencing is iatrogenic from the hormones that we are providing women to stop pregnancies. So think about perimenopause, do a workup, check your testosterone and estrogen levels. Consider testosterone topically for those who may be losing their testosterone in that age group. Testosterone gels can be used, and also way lower dose testosterone in the actual vulva. Vulvovaginal estrogen for de-estrogenification is very important. And then refer anything that you don't recognize, especially if you see a distinct lesion. But if the clitoris is phimosed, that clitoris needs to be released in most cases. Please refer to somebody who knows what they're doing. And the International Society for the Study of Women's Sexual Health has a list. So the ishwish.org, you can go there and find practitioners who know this stuff. And then just to mention flibanserin, in case some of you have heard about it, it's for hyperactive sexual desire disorder. And it is it was originally an antidepressant. It's a selective 5-HTP1A receptor agonist, and it blocks the 5-HT2A. And so what it does is it just actually promotes a little bit more of the serotonin in the right areas for pleasure versus blocking it with the serotonin. It does help minimally, but if all those other things aren't attended to, it's not going to help enough. So start with all the other things and come to flibanserin if you have no other choice. Okay, that's it for the sexual libido talk and the sexual pleasure. We'll come to questions at the end. Let's jump into sex differentiation. I don't know if you guys can tell what the gender of this child is. I've purposely left out the genitalia just to remind us that the genitalia is not going to answer that question for us. I've got that same slide I had before about the intersex genitalia, and intersex genitalia is just some of the many, many, many ways in which sex differentiation is diverse in nature. And maybe we don't need to say it's a boy, it's a girl. We could just say, oh, it's a happy baby, yay! And then we can discuss all the other things after that. One of the things we've done in medicine a lot is put our values into our research and then proven our own truths to ourselves over and over again. And that's a talent that humans have. We have a bias, we bring it in, and we study the bias, and we get the biased result. And one of the ways we do that is we decide if something is diverse or wrong. So in terms of hair color, there's just a completely broad spectrum of the possibilities of hair color. And we never say, oh, well, but it's wrong if it's blonde, or it's wrong if it's brown, or if it's wrong if it's black. We don't do that with eye color either. But with sexual differentiation, there was a right, which was either female or male, and then everything else was wrong. These were errors. This was an error in the SRY gene. This was an error in the chromosome. This is an error in the formation of the hormone receptors. No, they're not errors. They could just be variations in nature. Every snowflake is different. Every sexual expression may be different. So if you just even think about the number of different chromosomes combinations that are out there, sure, there are some that are more in the middle of the normal curve, but out in this second standard deviation, we still have a whole bunch of things that would be considered normal in a normal curve. And so just because they're more rare doesn't mean that they're not natural. And we've had diverse genders since the dawn of time. We're going to have them forever. So how do we get to the point where we start treating people as normal humans when they're normal humans? So of course you can have SRY gene variation, and as you may recall from genetics, but probably not, the SRY gene is what determines the masculinization of the sex differentiation. And here's just a schematic. If you had an on-off switch at each of these areas of the SRY joint, SRY gene, and of course they're not on our off switch, they're variable switches. They're more like a dimmer switch. So when you think about all these different possibility of when masculinization or feminization may happen, depending on the use of the SRY gene, and then you imagine that each of those points could be a dimmer switch instead of an on-off switch. You can just think of all the possible intersex opportunities that are available through natural diversity. And then you think about hormone synthesis, like what if the hormones aren't working in the typical way? What if the hormone receptors have variations in their formation? What if once the hormone receptors and the hormones are working, the neurotransmitters have a variation in them, or their receptors have variations? And then let's think about aromatase. Well, we have so much aromatase in our brain. Determining aromatase helps androgens turn into estrogens. But if you've got all kinds of androgens running through your system and you don't have aromatase, well, guess what? You're not going to estrogenize. You're not going to get estrogen out of your androgens, and you're not going to have a female brain, even though you might have a female genitalia. So now you've got a person who feels quite male, but looks quite female. And the way to handle that person is just to treat them as they'd like to be treated. It's not that complicated, but we have opinions, and we like to say that God has the same opinions as us, even though every aspect of nature has shown that there is diversity everywhere and it can't be except here. So that's how I speak to people who try to tell me that there's a right and a wrong. I just caution them. So also, interestingly, there's the epigenetics and the environmental factors. So you can have a sexual gender differentiation that's occurring, but if you have a very serious viral or inflammatory reaction between the ages of 1 and 9, you can modify things like your aromatase expression. And therefore, even though you would otherwise have formed into a full-fledged this gender or that gender, you can have modifications just from a viral infection that would change your gender. So just think about the so many ways in which we can have variations and diversity in sexual expression. And the only thing that has changed is that we're starting to recognize it, and we're stopping trying to force people into the boxes on the right or the left and just letting them be exactly where they are. That's the only thing that has changed. Nature is diverse. Every aspect of nature is diverse. Only humans decided which part of it, whether this was an error or whether that was an error. They aren't necessarily errors unless we call them that. And probably the biggest human error is calling something an error when it's just a diversification. So if you don't understand that, or you meet someone who doesn't understand that, that's okay. As a family doctor, there's a ton of things that you need to refer and that you don't understand, and that you don't have. An MD doesn't give you the right to an opinion about everything. If you don't understand something, refer it to somebody who does. They have spent so much time in that practice that they're in a position to help that person sort through the right decisions for them within the society in which we live. If you don't feel equipped to do that, please refer them to somebody who does. Okay, so we're gonna jump to one. Do we have time for one more topic? Just barely. I'm gonna fly through this topic. Are painful female procedures painful? I know the question is a little bit rhetorical, but it's so important. There's a huge article in the New York Times about how much IUDs hurt and how little we medicate them. And the response from gynecologists is, stop blaming the gynecologists. We're doing the best we can. How about the insurance companies, et cetera, et cetera. But really, let's back up a bit, because this problem is bigger than we think. So we have a 24-year-old who presents to the emergency room in excruciating pain after an IUD insertion. An urgent ultrasound is ordered looking for perforation because she's in so much pain. The vitals seem reasonable, but again, when you think about a female, like lots of young women run around 100/60. So is this a high blood pressure? Is that a high heart rate? Probably for a healthy female, those are high. So the ultrasound shows the IUD in good position. Do we just send her home? Most people just send her home. So the question is, why do we keep gaslighting women for their pain? 30% of women cry for no reason. I've thrown that up there because that is literally what my preceptor in gynecology said when he pushed a speculum through a very tender vulva to a woman saying, no, 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 please stop, and squeezing my hand and crying. And this was his answer. So this is how he was raised in the profession. This is how he's teaching me in the profession. And it's just not true. 30%, there's no evidence to say 30% of women cry for no reason. In fact, University of Chicago tried to do a study on an analgesic, and they needed to acquire 50 women and 50 men to do these painful procedures, and then offer them placebo versus analgesia. Within a week, they had their 50 women, and it took them 6 weeks to decide they had to cancel the study because they had only acquired 3 men. It was very hard for the men to put up with the kind of pain that the women were able to put up with, no problem. And anyone who works in an emergency department knows that it is not the women that are vocal and loud about smaller amounts of pain. As a matter of fact, the stoicism of women, especially women of color, is astounding. If a woman is quiet, it does not mean she's not in pain. If she's crying and vomiting, it's probably not because she's hysterical. Okay, so female painful procedures are typically undertreated. I'm just going to throw up a bunch of things here. If you have a chance to read through them, it's great. But if not, it's okay. But I just want to say, if a man cried or fainted or vomited from a procedure, probably one man, or especially if 2 men did that for the same procedure, we would very seriously consider changing all the guidelines for that procedure. We would not wait 15 years to do poor studies on whether Tylenol helps or doesn't help, whether Advil helps or doesn't help. We would really quickly consider sedating them because we don't like it when cis white men cry or vomit. When women cry or vomit, they're probably just hysterical. So even though female doctors have reported the intense pain and being dismissed and having PTSD from these procedures, we are still very slow to recommend pre-medication for these intense procedures, histosalpingograms, vulvar biopsies. They get local freezing, and then the woman's driving home and the local freezing's wearing off, and she's had a vulvar biopsy, and you didn't even give her Tylenol or recommend it or Advil or anything, or suggest that someone else drive her. We would not be doing this to men who are getting a penile biopsy. Sedation's almost never offered, which is very interesting because and there's so much backlash. Well, we can't afford to do sedation on all these women for such a simple procedure. As someone who has had colonoscopies without sedation and IUDs without sedation, I can tell you that the colonoscopy is like really uncomfortable period cramps, the kind that I've had to go to work with many times in my life. The IUD is excruciating. But we never, I got argued against for so long wanting to have the procedure without sedation, and I was never offered a thing for the IUD. So we really do have a completely different approach to procedures that involve men versus procedures that never involve men. And it's mostly because those procedures were done by men on women who must have been hysterical. That's why they were vomiting. And even if you read the literature, there's so much about the anxiety of the woman as opposed to the actual pain she's experiencing and the anxiety that comes from having an operation without any sedation whatsoever. So pardon my exaggeration, but if we were doing these IUDs on men, we would probably hospitalize them for 3 days and feed them Jello. So really consider this. As you know, Dr. Sims is credited for so many of the father of gynecology, and some of you may recognize these statues, but these are honoring the heroines, Anarcha and Lucy and Betsy, who suffered many brutal surgeries with mild opioid medication. at the beginning of under the knife of Dr. Sims, who was trying to help them with something that they did have, but the amount of surgeries done without proper sedation at that time has carried forward, and we still don't treat women properly for their pain. We don't treat people of color properly. We don't treat trans women properly or trans men. The only people who are really properly treated for their pain is a cis white man expressing pain. That person will be heard, and we will have quick modification of the procedures to accommodate that. So really pay attention to yourself and your reactions when someone's having a painful experience in front of you. And are you being habituated into a habitual learning that women crying is normal? So just as an example, here's one of the studies that I found when I was preparing this talk a few years ago. They're studying naproxen versus placebo for this procedure. Imagine a rigid cystoscopy study with placebo and Advil. Like, it's just mind-boggling what we will put women through, even for science. And women are often offered nothing. So it's no surprise that we can even get ethics to do this study, because it's not a very painful procedure. Yes, it is. And then they compared it to 50 milligrams of tramadol. That's one Tylenol 3, ladies and gentlemen. That is a tiny amount of tramadol opioid for an excruciating procedure for many, many women. And then they did see that tramadol works better than Advil, surprise, surprise, but they didn't even study putting the two of them together, and they didn't study like a healthy dose of tramadol, which would be a very non-harmful dose, but we would rather have the harm of the PTSD associated with like having a live, awake, non-sedated procedure that is excruciating, and that experience of the practitioner who says, this isn't a painful procedure. I can't understand why you're crying and vomiting. I think you're overreacting, which is very commonly what I hear from women. These are headache doses. We wouldn't give someone a colonoscopy with 50 milligrams of tramadol and compare that to placebo or naproxen. So we shouldn't do that for the IUDs either. So, oops, there we go. So we do need a lot more studies that actually study full access to medical care. So how do we do this? What would it look like if we treated female procedures like everybody else? Well, we would think about how you manage chronic pain or how you manage sedation for a procedure, and take from all those things. So what is a sedation? Well, we would give as much anti-inflammatory as we could. Of course, we wouldn't use oral Tylenol because we're giving IV medications. Typically, we would use propofol or something that will help them have no pain, help them forget their pain, help them be unconscious for the procedure. But in the absence of that, what can we do orally? We should do everything we can. We should give max dose of NSAIDs, max dose of Tylenol, a significant amount of opioid. Make sure that person has a ride home. If you think that that's going to limit the practice of IUD insertions because you're giving them opioids and now they need a ride home, consider they shouldn't be driving in that much pain. And accidents happen from pain just as much as they happen from opioids. Tell that person they need a ride home. It's okay. We get ride homes for our colonoscopies too. They should have an anxiolytic. If they need an anxiolytic, it's part of sedation medication. And then do a local block. There's a lot of evidence that an intracervical block during a procedure like an IUD is very, very helpful. Use your buffered lidocaine and inject the cervix. There's not very much pain for injecting the cervix compared to the pain and make sure that the needle's going far enough in that you're getting towards the internal os, especially on the side that you're going to place the tenaculum. And then, we're talking in Canada a fair bit about Penthrox. I remember from labor that Entonox did nothing. So when you think about Penthrox, make sure that the evidence is coming up to show that it helps. It does say that you can't use Penthrox with anything else. So does a combination of all the other 5 work better than just like inhaled analgesic? That's a research that needs to be done. So again, all those things need to be studied, and consider nerve modulation. That cervix is innervated by the vagal nerve, and there may be some nerve medications that would be helpful as well. In general, just think about a multi-angle approach to real pain and consider that these people are in excruciating pain just for a moment. So if we're not going to sedate them for some bizarre reason, just out of habit because we never have, then what can we do to mitigate that procedure? Think of histocalpingograms, think of vulvar biopsies, think of LEEP procedures. Like, nobody's medicating these women. It's really awful, and they do walk away traumatized. I know, because I see them afterwards. So do acknowledge their pain, forewarn them when they're going for something, like what it's going to be. If their doctor asks, tell them to ask about pain control for the procedure. If their gynecologist says, oh no, it's not a painful procedure, it's just not true. It's a painful procedure. So at least let them take the Tylenol and Advil, and maybe give them a couple of Tylenol 3s to help them through, and make sure that they have a ride home. And okay, so I think we've covered all of that. Offer pain control, yes, and I think, and then ensure ride home, we've covered it. So that's me. I'm Dr. Teresa Wood. We're almost out of time for questions. I apologize. I'll take any questions I can, and please reach out to me over Instagram if you have any questions I don't have a chance to answer today.
Wow. Thank you, Dr. Wood. That was quite the tour. Very appropriate given the fact that it's Pride Month, I guess, in both our countries. So the importance of sexual health and managing the pain in women patients is key. See if we have any questions. One is, can you discuss anal stimulation and how this plays a role in their sexual health?
Oh, definitely. So penetrative sex, I've kind of given it a bad rap in this talk, but I didn't mean to. It's actually extremely pleasurable for people of all genders to receive, to have that feeling of fullness, to have their sphincters, given the pressure, and to have that deep feeling of connection with another person. And that can happen through the anus, or through the mouth, or through the vagina. And all of those things are extremely pleasurable. I was giving them a bad rap in terms of replacing clitoral stimulation altogether, because it's the clitoris and the penis orgasms that do reward us at the nucleus accumbens. But definitely anal sex and oral sex and vaginal intercourse are extremely pleasurable for so many people, either with fingers or with dildos, toys, penises, anything. Obviously, you need to use protection if you're going to be with more than one partner, or if you're not in a monogamous relationship. But those things are obvious. And as Dr. Carol Queen liked to say in the 90s, when I was giving the female ejaculation talks and she was giving the anal sex talk, she said, if the lube isn't dripping from the ceiling, you're probably not using enough. And it's good to start low and go slow, just like one finger, then another finger, just like in the vagina. The vagina likes to be stimulated by one finger, and then two fingers, and sometimes three fingers before it receives anything bigger than that. It's like a warm-up process, and it decides if today's the day for it. So anal sex is similar, using a gloved or ungloved hand to put one finger, then two fingers, and just to gently coax that anal sphincter can be helpful. And then in terms of the person receiving the anal sex, it's a little bit counterintuitive, but the two things to keep in mind are, one, that the rectum is empty almost all day, except when you feel the urge to go to the bathroom. So if you're someone who uses the bathroom once a day, literally the rectum is going to be full for about 10 minutes a day. And the rest of the time, you don't need to do a major prep or anything like that. And then the other counterintuitive part is that a lot of people kind of clench up when they're trying to receive anal sex, and it's actually the opposite. To open that sphincter, you have to bear down. So if you want it to go more smoothly, you use a lot of lube, and the receiver needs to bear down. And it's definitely the first 2 inches of the rectum, just like the first 2 inches of the vagina. There's just tons of erectile tissue, tons of nerve endings, very much enhancing the sexual pleasure for people. The prostate and the periurethral sponge in the more female people have a lot of nerve endings around that as well, and love to be stimulated. So that's an excellent question.
Right. We're at 9, so I think we're going to have to close. Really, just thank you very much. Going from approaching this with shame to approaching this with insight, and judgment, and how we provide optimal care in this area is really crucial. So again, thank you very much for your talk, and everybody have a good weekend.
Thank you.